Hi dear friends, today we are going to talk about the nerve injury and techniques of nerve repair. As we said before, after the talk and the lecture about the brachial plexus, now we have to know some of the techniques we use to repair nerve injured, whether brachial plexus or other peripheral nerves. Before starting, you should know the cross-section of a peripheral nerve, and you should know the names of the fibrous tissue surrounding the nerves and how it is divided into several compartments. So actually, in a cross-section of a nerve, the nerve, as you know, is formed of axons of the anterior horn cells and some going back with sensation to the dorsal horn in the spinal cord. So each nerve, the unit is the axon. Axon of the nerve is covered by myelin, which is a fat, and the myelin is covered by a sheath, which is the endoneurium. So if you see this cross section, the blue is the nerve, the surrounding is the myelin and the endoneurium. The first cover of the nerve is the endoneurium. Then the nerve is divided into a group of small nerves called the fascicles. Each fascicle is surrounded by a fibrous membrane called the perineurium. So we have several perinuria in one nerve. And then the outer cover of the nerve is the epineurium, and it is very important. It is the layer where we take the stitches for nerve repair most of the time. And we have some blood vessels and venous drainage in the interstitial tissue between the perineurium. So again, we have axon, myelin, endoneurium, perineurium, and epineurium. So that when you are going to discuss it, you are going to be well oriented with it. And we talk about the nerve injury. As you know, the nerve injury, there is degeneration in the distal part of the nerve after it's cut. The proximal part doesn't degenerate because it is connected to the cell. It is connected to the motor or sensory cells, so they do not degenerate. The distal stump after the nerve is cut or injured is degenerated by a process called Wallerian degeneration, and it is an active process, and it's anterograde degeneration. It occurs later on after nerve injury, and it occurs, as we said, in the distal part of the axon, and it starts occurring from day 7 to day 21 after the injury. And after that, we have some changes for regeneration. Nerve fibers shrink back and rest for 1 month if the circumstances are optimum. If we did a repair of the nerve, then we get a shock stage of 1 month, no growth of the nerve, then the nerve starts to regenerate. And this answers a very important question asked by the patients and their families. After how long I'm going to recover? You calculate 1 month and then a growth rate of 1 millimeter per day. So the more proximal the injury, the longer it will take. In brachial plexus injuries, for example, an injury after repair may take up to 2 years to regenerate for the axons to grow from the brachial plexus, from the roots down to the muscles. The journey may take up to 2 years. This is what we call the Wallerian degeneration, a diagram of a nerve. This is the axon, normal neuron. Here it is injured, and then changes occur in the distal part of the nerve, as we said, where macrophages start to eat the axons, which are fragmented, as well as the surrounding myelin. At the same time, you get proliferation of the Schwann cells of the fibrous tissue surrounding the nerve, which is the epinurium, perinurium, and endonurium. And this, as we said, the Wallerian degeneration starts 2 weeks after injury, and the distal end is clean 3 weeks after the injury, as well as some of the proximal axon will divide into many branches. If a good repair is done, what happens is 3 months after the injury, the axons will disappear, and one axon will continue growing and get remyelinated again, surrounded by myelin and surrounded by Schwann cells, and the muscle is working. It's becoming regenerating. But if there is unsuccessful nerve regeneration or unsuccessful surgery, the axons will intermingle with the Schwann cells proximally, and all the tubes, the distal tubes, will be obliterated by the proliferation of the Schwann cells. So again, injury, 2 weeks after injury, and 3 weeks it becomes clean and ready for regrowth. If regeneration, if good repair is done, it acquires again the myelin and the Schwann cells. Bad repair, we get fibrosis, intermingled axons with Schwann cells, and obliteration of the endo, epi, and perinurium by Schwann cell proliferation. Stages of nerve injury. There are two major or two famous classifications for nerve injury. The Siddons classification is the old one. It is a very simple classification. It is neuropraxia. Neuropraxia is nerve concussion. The nerve is intact, as well as the axons and the myelin and the sheath surrounding the nerve, but it's not working because of this concussion. And it might work again from prolonged compression or from a tourniquet or from a trauma to the nerve. Stops working, then it is regenerating because the nerve is intact. So it recovers, I mean. Axonotmesis and neurotmesis. Axonotmesis, mesis means cutting. So axonotmesis is cutting of the axons. Neurotmesis is cutting of the nerve. So in axonotmesis, you get damage of the axons and with or without the endonurium, and neurotmesis, there is complete transection and cut of the nerve, including the epinurium. So this is Siddons classification: concussion, cutting of the axons, cutting of the whole nerve. But as you see, there are different situations, so a more detailed classification was suggested, and this is Sunderland classification. It has the same first and last. So like Siddon, Sunderland grade 1 is neuropraxia, and like Siddon, the grade 5 is neurotmesis. The problem with the Sunderland classification is in axonotmesis. He said, if you get damage to the axon with intact endo, peri, and epinurium, it is grade 2. If you get damage to the axon together with the endonurium, with intact perinurium and epinurium, it is grade 3. If you get damage to the axon together with endonurium, perinurium, and intact epinurium, it is grade 4. And of course, if you get damage to the axon with whole sheaths, it's grade 5 or neurotmesis. So the difference between Siddon classification and Sunderland classification is in the level of or at the stage of axonotmesis, depending whether the axon was damaged alone, grade 2, or damaged with the endonurium, grade 3, or damaged with the perinurium, grade 4. If the epinurium is damaged, it is complete cut of the nerve and grade 5. Timing and technique of nerve repair. Regarding the timing, there is the rule of 3. If it is a clean, sharp injury, should be repaired in 3 hours. But in peripheral nerves, we say from 3 to 6 hours. But for brachial plexus, we can stay for 3 days. Why? Because the results of the secondary repair of brachial plexus is not that good. So if you have a sharp injury of the brachial plexus and seen within 1, 2, or even 3 days, you can attempt direct repair. If the nerve, it is an open injury, of course. If it is an open injury, brachial plexus injury or any nerve injury, but the nerve is ragged, contused, or seen after 6 hours, the repair should be after 3 weeks. And we'll see later why after 3 weeks. But you should bind the ragged ends to nearby anatomical structures, not to lose them and to prevent nerve retraction. So, open injury, within 3 to 6 hours, repair. Brachial plexus, open injury, clean, up to 3 days, repair. Ragged contused nerve, or seen after 6 hours, you postpone the repair to 3 weeks, and you put some stitches to the distal ends of the nerve to identify them when coming back after 3 weeks. If it is a closed nerve injury, we wait for 3 months because it could be neuropraxia and the nerve might recover. So we have 3 to 6 hours, brachial plexus up to 3 days. Ragged contused nerve, 3 weeks. Closed nerve injury, repair is within 3 months. That's why we call it the rule of 3. And this is the algorithm of brachial plexus injury. It is either an open injury, laceration, or transection. If it is sharply divided, as we said, we do a primary repair, and as we said, up to 3 days. If it is blunt and dragged and contused, you tack adjacent tissues and come back for the repair after 3 weeks. And if it is a closed injury, this means that the lesion is in continuity, whether stretch of the nerve in motorcycle injuries, whether there is wrong injection, whether there is a compression by the tourniquet, whether there is electrocution and ischemic changes of the nerve. Closed injury, you evaluate. You do clinical assessment, EMG, MRI, CT myelography if needed, and you follow. If there is no regeneration, no recovery, we do exploration of the nerve. Exploration, we wait, as we said, in closed injuries, up to 3 months. Why we say exploration? Because we might do just neurolysis, freeing the nerve from adjacent adhesions, or we either do repair or we do reconstruction with the grafts, or we do neurotization. So we call it, if it is closed and there is no recovery within 3 months, we explore and we do according to the situation we find inside. But of course, if it is regenerating and recovering, nothing to be done. So again, brachial plexus injury, open, closed. Open, clean, sharp, primary repair within 3 days. Blunt, nerve contused or ragged, or seen after 3 days, you tack the adjacent tissues, the nerve to adjacent tissues, repair after 3 weeks. Closed injury, we wait. We do, while waiting, clinical assessment, EMG, radiographs. If it is recovering, leave it alone, that's good. If there is no regeneration, you explore. When do you explore? After 3 months of waiting. Why 3 weeks? Because the time for Wallerian degeneration, as we saw, to occur, so that the endoneurium becomes empty. So all the tubes in the distal stump of the nerve become empty. Endoneurium is empty, there is no more axon, there is no more myelin, and the perineurium and, of course, the epineurium are there. So this allows growth of the proximal axon in these distal tubes. Why 3 weeks? Also because the epineurium after 3 weeks gets thicker. When it is acutely injured, it might be thin and might cut. To take good stitches. Why 3 weeks? Also because with the injury to the nerve, you get edema of the nerve. We find a very long segment could be apparently affected, but when you stay for 3 weeks, the nerve recovers from the edema and the real affected segment becomes shorter. And why not more than 3 weeks? Because, as we said, the Schwann cells in the endoperi and epineurium will fibrose and will prevent any regeneration. So, why 3 weeks? Because tubes are empty, epineurium we can take the stitches, edema subsiding, and if more than 3 weeks we get fibrosis and proliferation. The technique of nerve repair, the classic repair which is done now, most of the centers, is the epineurial repair. The outer sheath of the nerve, we take the stitches. Some 20 or 25 years ago, there was en vogue the perineural repair, which is the repair of the perineurium, what we call the interfascicular repair, but they found that too much stitches inside the nerve means too much fibrosis and bad result. And also, don't forget, don't put too many sutures to avoid fibrosis. So it's not good to put too many sutures in nerve repair, 2, 3, 4 stitches maximally in the epineurium. The less you avoid fibrosis. And every nerve end should be cut sharply. When you find a nerve injured, you cut in the nerve and you cut cross section in each end of the nerve until you get a part which is not fibrosed, which is yellowish in color and bleeding. This is the site where you can do the repair. So what about if I'm doing cutting of the nerve, proximal, I reached the root of the brachial plexus and still the nerve is fibrosed and still the nerve is not bleeding? We can do neurotization. Never to attempt to connect two ends of a nerve if one of them is fibrosed and not bleeding. So epineurial, interfascicular is no longer done. Don't put many stitches, and every end of the nerve should be cut sharply and having some bleeding from the surface. How to gain extra length if I want to approximate two ends and I have a loss. If I cut the fibrosed part and I get a loss, you can flex the nearby joint with plaster slab. You keep it for 3 to 6 weeks, while like working at the wrist for ulnar median nerve, and you want to approximate the hand to the forearm, you flex the wrist. You can sacrifice some of the sensory branches. How can I identify them? By nerve stimulation. You can do transposition of the nerve like the ulnar nerve to gain extra length, and if not possible, all this failed, to get the length you do a nerve graft. So again, this is the nerve, the axons, the endoneurium, then the fascicles, the perineurium, and then the epineurium outside, and there are arterial supply and venous drainage of the nerve. This is the technique of nerve repair. You leave the nerve itself in the normal anatomical position, and you take your stitches in the epineurium. As we said, we take 3-4 stitches, don't too much. And the most important here, when you tighten the suture, don't do too much tightening, because the axons will go out of the gap and will not recover. And don't do very loose sutures, because having very loose suture, we can have a gap in between and it will never repair. So stitches are taken, the nerve is put in anatomical position, stitches are taken in the epineurium, and they are tightened, not too much and not too loose. not too tight, not too loose. And we said why. And don't put too much stitches. Sometimes you can need 2, 3, depends. Nerve graft, the rules for the nerve graft also, it has to be longer than 15% the length. So if I have a defect of 10 centimeters, you put a graft of 11.5 centimeters because some retraction of the graft will occur. And the ideal grafting should be 2 to 3 millimeters in diameter, which is present in the sural nerve, as we'll see. Why not to take a thicker graft like the radial nerve in the forearm is a sensory nerve? Because it is receiving its blood supply, its nutrition in the first few days before revascularization by diffusion, nutrition by perfusion. So if the nerve is thick, perfusion will not nourish the central part of the nerve, and you get central necrosis of the graft and bad result. So remember, diameter of the graft never to exceed 2 to 3 millimeters. The length of the graft should be 15% more than the length of the defect. And also, I'll show you an example of the grafts. The most famous is the sural. Always, the sural nerve is a sensory nerve, and it is present behind the lateral malleolus, and we have the short saphenous vein beside it. You can, it can be perplexing for you, but always, if you cut the end and you find the cavity, this is the vein. If no cavity, this is the nerve. And then you start taking the length you want from the nerve. Usually we don't use long skin incision, but we, after identifying the nerve, we pass in the pathway of the nerve, we do small transverse incisions, we cut the distal end of the nerve, and then we pull the nerve from the incision above, and we pull more of the nerve, and we pull more of the nerve, and that's how we can avoid having a very long skin incision, but multiple transverse incision. So this is where we found it. This is transverse incisions along the pathway. Neurotization, you heard me talking about. What is the definition of neurotization? It is the transfer of a healthy and less valuable nerve. Of course, all nerves are valuable, but some nerves are very important and other nerves are of less value. So you put an unimportant nerve in the territory or in the place to innervate an important nerve in cases of irreparable damage to this nerve. So if an important nerve is injured and I cannot repair it, I take a nearby less important nerve and I do an anastomosis to take the function of the original nerve. Generally speaking, we can classify the neurotization into intraplexus or extraplexus nerve donors. The intraplexus nerve donor I take from the nerve itself, some fibers from the nerves in the same path and we from the same plexus, and we transfer parts of it to another part. One of the famous operations, the very successful operation, is Oberdeen operation, as we'll see it now. So it is an intraplexus nerve donor. Or I can take extraplexus nerve donor, where I can take a nerve totally from outside the plexus, like the spinal accessory, like the intercostal or phrenic. So interplexus from the same brachial plexus or lumbar plexus, extraplexus from a nerve nearby. The intraplexus neurotization is very useful in cases of partial brachial plexus injury, especially the upper trunk. You know that the brachial plexus, C5, C6, form the upper trunk of the brachial plexus, which supplies the proximal muscles, the brachialis and the biceps, which are responsible, and the deltoid responsible for the flexion of the elbow. And if 5, 6 or the upper trunk is injured, we can do anastomosis between branches of the ulnar and median nerve in the arm to the motor branches, to the brachialis and the biceps. You know that the brachialis and the biceps, as you will see, are supplied by the musculocutaneous. We don't put branches from the ulnar and median to the musculocutaneous, but we take the ulnar and median anastomosing with the branches of the musculocutaneous, motor branch to the brachialis and motor branch to the biceps. Oberlin discovered or described this approach in 1994, where he took a part of the ulnar nerve to the biceps branch, the motor branch of the musculocutaneous to the biceps. 2006, he remodeled, or he applied another addition. We take one part of the ulnar nerve to the biceps as before, and we can take one part of the median nerve to the brachialis branch. And this is the incision, where to do it along the medial aspect of the upper arm, where we can identify the ulnar and the median. And as you all know, there is no branches for the ulnar and the median in the upper arm. So we take a twig or a fascicle or two from the ulnar, fascicle to the biceps, fascicle or two from the median to the brachialis. Someone will tell me which fascicle to take, and how can I take fascicles? By nerve stimulation, you divide the median nerve first into fascicles in the area you are going to do your anastomosis, and you stimulate. And you take the fascicle where we get severe flexion of the wrist. So the median nerve gives the flexor carpi radialis. So we can take, when you find there is innervation of the flexor carpi radialis, the nerve, the fascicle that makes this, you take it and apply it with the brachialis. So you will tell me, what about flexion of the wrist? I will tell you that the muscles that cross the wrist joint, flexor digitorum superficialis and profundus, can still flex the wrist. So if you sacrifice the flexor carpi radialis, the fascicle supplying the flexor carpi radialis, you can still flex the wrist, and you use it to the anastomose with the brachialis. And the same for the ulnar nerve, the flexor carpi ulnaris, the fascicles that make it work by stimulation. You do an anastomosis between the ulnar nerve and the biceps. In this way, I took motor branches from the median and ulnar nerve and anastomosed them with the motor branches to the two important muscles responsible for the flexion of the elbow. If you flex your elbow and if you have a good hand grip, it is a useful arm. But if you have a good hand grip and the elbow cannot be flexed, you cannot make use of this hand. And this is an operative view where you can see the median nerve and taking fascicles of the flexor carpi radialis, anastomosing with the motor branch to the brachialis, and this is the ulnar nerve, and we take the fascicle from the ulnar of the flexor carpi ulnaris and anastomose with the biceps. In these cases, we don't anastomose with the musculocutaneous, we anastomose directly with the motor branches of the musculocutaneous. Excellent results. I've tried it more than 10 or 15 times. Because it is supplying a small group of large muscles, so the result is excellent. Within 3 months, you can get flexion of the elbow. The extra plexus neurotization is involving another nerve outside the plexus with the nerve from the plexus, like the spinal accessory, 11th cranial nerve with the suprascapular, or the phrenic nerve to the musculocutaneous nerve with Schurrer nerve graft. It's no longer done because you lose one lung, you get paradoxical respiration. It's not that Oberdien has replaced this. This is to show the extra plexus, the spinal accessory, and the suprascapular. They are close to each other, and you can anastomose them posterior triangle of the neck with graft. And this is the pathway of the suprascapular. Importance is that you get supraspinatus and infraspinatus muscle working. You can get abduction of the elbow. So in this case, you can help to have abduction of the elbow. And this is the picture showing the phrenic nerve under the sternemastoid in front of the scalenus anterior, and you cut it distally and you anastomose with the graft with the musculocutaneous. But as I told you, this is not done too much as before. And thank you very much for your attention. This is not all the details of the peripheral nerve injury, but it gives you an idea to put you on the correct track if you want to continue in this field. Thank you very much for your attention and hope we meet soon.